Mike asked me to show you guys a couple of cases in the tricuspid world as well as in the mitral TMVR world. I know you guys were just working on TAVRs before I walked in here, and I think for the vast majority of places that you're going to work, I think knowing obviously coronary CT, but then knowing TAVRs and understanding TAVRs will probably cover 90% of what you guys may do in clinical practice. The tricuspid and mitral stuff is kind of more of a niche area, and there's also a lot less in terms of national guidelines as to how to actually do these workups, and part of that is because there aren't that many commercially available valves in the tricuspid and mitral world. And so every single valve that we do, or the vast majority of the valves that we do, are in certain clinical trials, and so the workups all vary. There isn't like one established pathway of doing these evaluations. So I'll kind of show you more basic stuff today. So I've opened up a study that I prepared for this talk. And basically the way that this program works is you kind of define where you think the tricuspid valve annulus is. And so this is a patient who has severe tricuspid regurgitation. And the first thing that we do is we always go through and see if we can get a better idea of what is actually wrong with the tricuspid valve. And in this particular case, so as I scroll through the picture in the top right box, what you see is the valve right here. That's the tricuspid valve. And just a quick anatomy lesson, you have this tissue right here is probably your septal leaflet. If I could play it, you'll see that there's a commissure right here that separates the anterior leaflet that's going to be here and the posterior leaflet that's going to be over there. So now you can see a little bit better. And so you see the septal leaflet down here, you see the anterior leaflet that's up here, and this thing right here is probably the posterior leaflet. And you can see how the leaflets don't coapt in the middle, probably leading to their tricuspid regurgitation, and that the annulus of the tricuspid valve looks fairly dilated. So this is a classic case of functional tricuspid regurgitation. And so our job on the imaging side is we have to figure out whether or not we can put a valve in this person. And again, in the tricuspid world, prior to, I guess, a year and a half ago, we had no commercially available ways of doing a tricuspid valve replacement from a percutaneous technique. But then about a year and a half ago, there's a device that is now approved, and I'll show you here, called the Evoke TTVR. And this is like a quick 1-minute thing just to kind of orient you guys on how it works. But basically, you go transfemoral through the vein, and you go up into the right atrium. The delivery catheter sheath will cross the tricuspid valve. I'll fast forward here. And then there are these 9 little anchor points that will basically hook on or grab onto the leaflets. And that is what creates a dock for a valve that is then going to expand and eventually get deployed on the inside here. I'll fast forward, and this thing is going to kind of balloon open. And if you look at it from the top down, it looks like a spider. And so it's a tri-leaflet. I think it's a bovine pericardial tissue with a frame, with a nitinol frame, similar to the TAVR valve. So that's essentially how what the valve looks like and how essentially it gets deployed. And so moving back to the laptop here. So our job here is basically to define how big the annulus of the valve is going to be. And at the same time, we're also looking at the health of the leaflet tissue to make sure there's nothing flail. We're also looking down into the right ventricle at the papillary muscles to see if there's anything that would be, some sort of large pap muscle that might prohibit the valve from fully expanding. This looks like to me a pretty kind of straightforward case to put a valve in if the sizing is okay. And so the way that we size the annulus is we make measurements of the annulus in systole and in diastole. And that will help dictate what size valve. There's 4 different types, 4 different sizes of the Evoke. So probably early diastole versus late systole. And so our first job is to find with the automatic way, they will drop 16 dots along where they think the annulus is. And so we just go through and make sure that all 16 dots seem to be in a reasonable spot. As you get closer to the aortic valve, it gets a little bit tricky to see exactly where the annulus is, but I'll just tweak some of these dots a little bit here. But all the other dots seem reasonable. And so now if you look at this picture up here, now it's kind of traced out the annulus of the tricuspid valve. And if we want to measure it, we're basically the two important measurements that we make are what's called a septal. Remember the septal leaflet was over here, septal to lateral dimension, and then an anterior to posterior dimension. So you see here that it's roughly 50 millimeters in diameter. The largest Evoque tricuspid valve is 56 millimeters. So this would be in bounds for the device. Anything over 60 is probably too big, and anything below 35 would be, below 38 maybe, would be way too small. And so that's for the tricuspid. In the tricuspid world, it's really fairly straightforward in terms of what workups that we do. And I'll just show you, go back to the other computer real quick, show you real quick. Every one of these valves that we are intending on placing, raw DICOM images actually get sent to Edwards, and they have their own clinical team, imaging team, that reviews all of the imaging, both CT and echo, and then they provide us with their own report. They actually have to approve it before we can actually schedule the patient for implant. And this is an example of one that I think they sent us just last week, of a patient. And so they decided that a 44 millimeter valve would be best for this patient. You can see that they're making their own measurements. They also look at access. They also make a lot of other fancy measurements, looking at how the IVC comes up into the right atrium and the angle between the IVC and the tricuspid valve. They look at the RV dimensions. They look at all these different things. And most of these things are not absolutely not an absolute contraindication for approval. But for sake of time, I didn't go through all this stuff with you guys. But you can see how detailed these reports are. These are the echo images at the end, and then they finally give us within parameters, or if there's anything that we have to be careful of intra-op. But again, for the sake of the CT planning, it's mainly defining the annulus of the tricuspid valve and making sure that there's nothing anatomically funny in the case. The only other clinical trial that we're involved in, well, there's a few that we're involved in, but there seems to be technical issues with most of them. But the only other one is with Medtronic, and that's called the Intrepid trial. But we've had ever since this valve became commercially available, there's a lot less, takes a lot more inertia to try to get someone through a clinical trial when you can just send this to the Edwards team and they can schedule your implant, 2 weeks later. So from a patient standpoint, they're like, why would I wait for a clinical trial when I could get a valve that's already approved? All right.